Hello, everyone. A very good evening, a very good day to all of you. I'm Dr. Swati Varma and one of the mentors in MRCOG Part 2 Study Medic. So here we are again with the fresh module that is core surgical skills. As discussed earlier, in this RRR series, we are basically discussing the most recent exam tested questions which have been asked, especially in 2024 and 23. So let's again start with the question discussion, which will comprise of 10 SBAs and 10 EMQs, which are the latest ones. So as usual, first let's start with the quote that concentrate all your thoughts upon the work in hand. The sun's rays don't burn until brought to a focus. So please keep yourselves focused, keep yourselves energized and in full enthusiasm, keep on motivating yourselves towards your target, okay? And don't deviate. So now, first let's start with the SBAs. Coming to the first one, a 32-year-old woman undergoes an elective cesarean section at 39 weeks due to breach. Now, during the procedure, she develops significant PPH that is unresponsive to uterotonics and conservative measures. Despite multiple blood transfusions and attempts at uterine repair, the decision is made to perform a hysterectomy to control the bleeding. Now, what is the approximate incidence of hysterectomy following cesarean section in such cases? Now, this is a question which is based on cesarean section consent advice. We should have an idea as to what is the approximate percentage of a patient undergoing cesarean section requiring peripartum hysterectomy. So based on that, the correct answer is 0.2%. So the correct answer is approximately 0.2% based on this table. Here we can see that they have given a comparison between planned cesarean birth and planned vaginal birth. The percentage of various, or you can say the incidence of various complications, the risks for the woman. So if we search for emergency hysterectomy, so it comes out to be around 200 per 100,000. So we should have a rough idea that about 1 in 100 women require emergency hysterectomy while they are undergoing a planned cesarean birth, whereas 1 in 1,000 will require an emergency hysterectomy while they are undergoing a planned vaginal birth. So that's why the correct answer is, if we convert it into percentage, so it will come to be around 0.2%. Again, this table is from NICE guideline. Again, cesarean birth NICE guideline says peripartum hysterectomy about 100 per 100,000 women. So that's why that is for vaginal birth and 200 per 100,000 for cesarean birth. So this again comes out to be, if we calculate the percentage, it will be 0.2%. So hence the answer. Incidence of hysterectomy is approximately 0.2%. It is especially performed if any postpartum complications arise, like PPH, as in this scenario, or placenta accreta spectrum disorders, where it might become a bit higher, uterine rupture, particularly in women with previous C-section. But modern advances in obstetric care, including effective hemorrhage control protocols and improved surgical techniques, have contributed in keeping this rate or this percentage low. If we look at other options, option A is 0.01%, so that's quite low. It's underestimating the true rate. 1%, again, it may be seen in high-risk cases like placenta accreta, but in the overall population, it's not 1%. 5% and 10% are obviously over projections. So in highest risk cases, it is 5%. 10% is not at all consistent with hysterectomy in general population with cesarean section. So it's an extreme overestimation. Hence, we arrive to the conclusion that 0.2% is the correct answer. Risk factors, if we look at hysterectomy, in which women hysterectomy might be required during cesarean section. So if there are prior cesarean sections, placenta previa accreta, uterine rupture, severe infection, in such cases, the risk of women requiring hysterectomy during cesarean section becomes more. Okay. All right. Then next come to the second question. Mrs. Leanne Brown, a 37-year-old woman, is attending her gynae clinic appointment for ongoing management of her moderate to severe endometriosis. During consultation, she asks about potential complications associated with her condition. Doctor explains that bowel perforation, while a known complication of endometriosis, is considered uncommon. Now, uncommon means how much in terms of incidence and clinical practice? Now, here it becomes a bit confusing. Why? Because in our tables, we have read a particular range, like 1 in 1 to 1 in 10 is very common, 1 in 10 to 1 in 100 common. So like here, they have not given range. If they are giving range, it's very simple. We can just put the answer. But if they are giving uncommon and we have to choose, then choose the first one. Like suppose here the answer is 1 in 100. How? Uncommon refers to a condition or complication with an incidence of 1 in 100 to 1 in 1000. So please consider it like 1 in 100 to less than 1 in 1000. Then, so uncommon indicates that such complications, while not frequently encountered, occur often enough to warrant recognition and patient counseling. This in general denotes like how to counsel about uncommon complications and bowel perforation. Here, actually, these things are not important. Here, they are focusing on our understanding about common, very common, common, uncommon, these terminologies. So 1 in 1000 corresponds to rare, which represents a lower frequency of occurrence than uncommon. And very rare means 1 in 10,000 to 1 in 100,000. Extremely rare is still less. So uncommon refers to conditions with an incidence of 1 in 100 to less than 1 in 1000. Okay. And proper communication should always take place while explaining the risks. In core surgical skills module, you are expected to know the approximate incidence. What is the meaning of very common, common, uncommon, rare, very rare, and the major complications. You should have a rough idea of the incidence of major complications, especially for vaginal delivery, for cesarean section, for hysterectomy, for diagnostic laparoscopy, hysteroscopy. These common procedures, you should be clear with the risk of major complications. So this is the table. If they give 1 in 1 to less than 1 in 10, so this becomes very common. 1 in 10 to less than 1 in 100 becomes common. 1 in 100 to less than 1 in 1000 becomes uncommon. Okay. So consider this interpretation like that. If they are giving a range, then it's quite simple. You should be well aware of the range. Otherwise, you will choose this one. Coming to the next question, Mrs. Annie Walker, a 45-year-old Jehovah's Witness, underwent a total abdominal hysterectomy for uterine fibroids. She had previously refused blood transfusion due to religious beliefs and signed an advance directive. Advance directive is present with her. On post-operative day 1, she develops heart rate 120, blood pressure 90/60, dizziness and confusion. Now she is getting hemodynamically unstable. What is the next best step in management if internal hemorrhage is confirmed post-operatively? So now, immediately in our minds, first thing will come that she is losing blood. So something we have to give blood. But she's Jehovah's Witness. She has signed an advance directive. She has refused blood transfusion. So we have to look for any other option. Respect the advance directive and provide no further treatment. That would not obviously work fine for her. Administer FFP and platelets. Right now, it would be of no use. Administer blood transfusion in the patient's best interest. We can't. She's an adult with an advance directive. We can't violate. Use alternative measures like cell salvage and erythropoietin. Seems to be a reasonable option. Monitor closely and observe for further deterioration. We can't leave her as such. So the best option out of these is cell salvage and erythropoietin. Let's analyze. In this scenario, alternative blood conserving measures like cell salvage, erythropoietin, and iron supplementation must be used to address her anemia and hemodynamic instability. Because These strategies are often acceptable to most Jehovah's Witnesses. So it is very essential that any patient who is Jehovah's Witness, her surgery or her delivery is carried out in a center where adequate facilities for cell salvage and these things, erythropoietin and all such facilities should be properly available. Multidisciplinary input should be available. Analyzing other options, respecting advance directive is crucial, but this doesn't mean withholding all treatment. Appropriate alternatives must be sought for. FFP and platelets won't be adequate to correct the anemia. Administering blood transfusion in her best interest would violate her autonomy and advance directive. So even in critical situations, her wishes have to be respected as she is an adult. Monitoring closely, just observing without any intervention is obviously inappropriate given her hemodynamic instability. Okay. So if we look at the key learning points, it stays the same. Advance directive has to be respected. Options like cell salvage, erythropoietin, and iron supplementation should be sought for in managing anemia, at the same time honoring the patient's wishes also. Combined supportive measures like IV fluids or oxygen, initially these should be resorted to, but they are not definitive measures. Okay, so definitive measures, if they are asking for, then cell salvage and erythropoietin. Multidisciplinary team involvement is a very important thing. You have to always look for options like this. Managing an appropriate center, tertiary care center involving multidisciplinary team, adequate expertise in intraoperative cell salvage, all these kinds of things should be present. Coming to the next question, Miss Clara Thompson, a 28-year, presents with a 1-year history of infertility and intermittent pelvic pain. A decision is made to proceed with DL, that is diagnostic laparoscopy, to evaluate for endometriosis and assess tubal patency. During pre-op counseling, she inquires about the potential risks associated with the procedure. So what's the most common major complication of diagnostic laparoscopy? Out of these, if we look, infection and bleeding are minor risks. Whereas injury, visceral injury, bowel injury, bladder injury, vascular injury remain major risks. So now we have to choose the most common. So most common remains bowel injury, right? So bowel injury is a significant complication with the risk heightened by factors like previous abdominal surgeries, adhesions, or endometriosis like here. So bowel injury, although rare, can lead to serious complications like peritonitis, sepsis, need for further surgeries, interventions. Causes may be use of Verey's needle for insufflation, during insertion of trocar, or while extensively dissecting during the procedure. So if we look at the statement of GTG, that is preventing entry-related injuries in laparoscopy, the rate of major complications is 1.4 in 1,000, comprising intestinal injuries, maximum 0.6 per 1,000, urological injuries 0.3 per 1,000, and vascular injuries is still less, that is 0.1 in 1,000. So these percentages, guys, are actually very important, and because they have been repeatedly asked in various recalls. If we look at other options, post-operative infections like pelvic abscess are possible, but occur less frequently than bowel injury. Also, they are not major risks. Bleeding can occur due to vessel injury, but is generally less common. Bladder injuries are uncommon, more likely during procedures involving extensive pelvic dissection like hysterectomy, because the area near bladder, if it is being manipulated upon. Then again, injury to major vessels, although it is rare but catastrophic when it occurs, but still, again, they are asking most common. It is less common than bowel injury. So if we look at common complications, minor pain or discomfort, mild bleeding at port sites, whereas significant complications are bowel, vascular, bladder injury, and yes, infection. Might be, if there is serious infection, it may become a major complication, significant complication, but infections which are very manageable, mild infections, they are minor risks. Looking at risk mitigation, careful patient selection, thorough pre-op assessment is a must. Use of imaging to identify adhesions or anatomical abnormalities, especially in such high-risk cases like previous Cesarean sections or endometriosis. There is high possibility of injuries happening. So patients should be informed about all these rare but serious complications, and need for further intervention if in case such complications arise. Coming to the next question, Ms. Sarah Michelle, a 32-year-old woman with a history of chronic pelvic pain, is scheduled for diagnostic laparoscopy. During pre-op discussion, the surgeon explains the risks, including the possibility of vessel injury during umbilical port entry. Now, which vessel is most at risk of injury during entry in laparoscopy? Umbilical port entry in laparoscopy. So here again, this is a very commonly asked question. This should be, you all should be very well aware of this vessel, which is most at risk of injury. That is the inferior epigastric artery. So inferior epigastric artery is at the highest risk of injury during umbilical port entry. Why? Because of its close proximity to abdominal wall and the umbilicus. Focusing at some important anatomical points, it arises from external iliac artery, runs along the posterior aspect of the rectus abdominis muscle, and during laparoscopy, the Veress needle or trocar can inadvertently injure this vessel. So for prevention, we should carefully place the ports lateral to the midline and visualize inferior epigastric vessels under transillumination. If we look at other options, external iliac artery is located deeper in the pelvis, so less likely to be injured. Aorta, it lies in the retroperitoneum. It's rarely injured during initial entry unless Veress needle or trocar is inserted deeply or improperly, or patient is very thin, means risk factors are there. IVC, similar to the aorta, it is retroperitoneal and is less likely to be injured. Superior epigastric artery, what about this? This supplies the upper part of the rectus abdominis, and typically it is not at risk during lower abdominal entry, right? So if we focus at key learning points, the basic lesson which we derive is the inferior epigastric artery is most commonly at risk during abdominal port placement near the umbilicus. Safe entry techniques, pre-entry imaging should be carried out when indicated, but safe entry techniques are always to be done. Prompt identification and control of bleeding is essential. If suppose you have recognized that vessel injury has happened, immediately take adequate measures. Suturing, electrocautery, or sometimes in severe cases, conversion to open surgery might be required. Coming to the next question, a 42-year-old woman presents to the gynae clinic with a feeling of pelvic heaviness and urinary incontinence. On examination, she is found to have uterine prolapse. The gynec explains that the condition is caused by weakened pelvic support structures and mentions the primary ligaments involved in supporting the uterus in endopelvic fascia. Now, which ligaments provide the primary support to the uterus in the endopelvic fascia? So here, primary support, we have to look for cardinal ligament. So cardinal ligament is mentioned in option C. Cardinal and uterosacral remain the primary support. So here, look how important it is to be well aware of the pelvic anatomy. We can't ignore pelvic anatomy at any point of time. It can be asked. So cardinal ligament, that is the transverse cervical ligament, and the uterosacral, they are the key structures in the endopelvic fascia providing mechanical support to the uterus. Looking at its anatomy, cardinal ligament extends laterally from cervix and upper vagina to the pelvic side wall, and uterosacral connects the posterior cervix to the sacrum. Together, they ensure that uterus remains centrally positioned and resists downward displacement. Broad ligament as such is a fold of peritoneum that stabilizes the uterus but doesn't provide substantial structural support. Ovarian ligament supports the ovary, of course. Round ligament maintains the anteverted position of the uterus, but as such, providing mechanical support, it provides little. The pubocervical sacrospinous ligament, they support the bladder and provide anterior stability. Sacrospinous supports the pelvic floor, but doesn't directly support the uterus. Broad and round ligament, we already discussed. Hence, the correct answer becomes cardinal and uterosacral ligaments. Next, a 45-year-old woman undergoes a total abdominal hysterectomy for uterine fibroids. Post-op, she develops burn-like lesions on her lower abdomen and thigh. The surgical team recalls that monopolar cautery was used with a plastic sheath for bolt cutting during the procedure. So what's the most likely type of burn in this case? Monopolar cautery. Most frequent type of burn associated is electrical burn. So it delivers high frequency electrical energy for cutting or coagulation. Sorry. If the energy isn't properly grounded or leaks from insulation, then it is known to cause electrical burns at unintended sites, like here. So they are a result of either current leakage or somewhere inadvertent or improper use of the cautery device has been done. Why other options are incorrect? While heat is involved, but this injury isn't directly caused by high temperature, but by leaked electrical energy. Friction burns is known to occur from mechanical rubbing, not relevant in this case. Contact burns, when skin directly contacts a hot surface. Here it is electrical. Chemical burns is obviously from exposure to corrosive substances, not involved in this scenario. So look for electrical burns option in this case. It may include improper grounding, insulation failure, or equipment malfunction. So to prevent such things, we ensure proper grounding of the patient, regularly check the integrity of the cautery device and insulation, evaluate the depth and extent of the burn, and treat as a standard burn injury. Coming to 8th question, a 37-year-old woman, Gravida 3, attends the gynec clinic for permanent sterilization after completing her family. She opts for a laparoscopic Filshie clip procedure. Here it would be para 3, right? The surgeon explains the mechanism and materials of the clip before proceeding with consent. What's the primary material used in the Filshie clip? Now, this explores our knowledge regarding the structure of the Filshie clip. We should be clear about what material is used to make Filshie clip. So the correct answer here is A, that is titanium lined with silicone. Titanium, it provides strength, corrosion resistance, and biocompatibility, ideal for long-term implantation in the human body. Silicone lining does what? It cushions the fallopian tube during compression, hence reducing tissue trauma. Also, it ensures effective occlusion by promoting fibrosis and ischemia at the clip site. Stainless steel, if we look at this option, it lacks the same level of biocompatibility and Teflon isn't used in Filshie clips. Why not titanium alloy? They are biocompatible, but Filshie clips are specifically using pure titanium with silicone, not polyethylene. Platinum isn't used in sterilization clips. It's expensive, lacks the structural benefits. Aluminium as such is not suitable for long-term implantation because of its corrosive action. Hence, the most feasible and the correct option remains titanium with silicone lining. Clips, if we look at a little bit more detail, they are applied laparoscopically to the mid-isthmic portion of the tubes, permanently occluding them. They are lightweight, corrosion resistance, and tissue-friendly. Permanent contraception and failure rate is very less. Coming to the second last SBA, a 45-year-old woman is undergoing a TAH for uterine fibroids. During the surgery, the surgical team notices significant smoke production, requiring the use of smoke evacuation systems to maintain visibility and ensuring staff safety. So which instrument used is most likely causing the highest level of smoke spread in the OT? So here the most likely instrument which is causing this is monopolar diathermy. It's the instrument most commonly associated with significant smoke production in surgeries. It works by applying a high frequency electrical current to tissues. As we saw earlier, it causes thermal vaporization, resulting in substantial smoke generation. Ultrasonic scalpel uses mechanical energy through vibrations, so much less smoke is produced. Advanced bipolar thermy, current is confined between the two electrodes, hence it minimizes tissue vaporization and smoke. Mixed diathermy combines different energy types, but as such smoke production is lesser as compared to monopolar diathermy. CO2 lasers, although produce smoke, the amount is lower. So we derive the key learning point that monopolar diathermy causes the highest level of smoke due to tissue vaporization. Surgical smoke as such contains hazardous chemicals, particulates, and potential pathogens. Exposure can lead to eye irritation, respiratory problems, and long-term risks for the staff. Ideally, if we use safety measures, we use smoke evacuators, adequate ventilation, we might use masks. Instruments like ultrasonic scalpels and bipolar diathermy should be preferred because they produce less smoke. The last SPA, Mrs. Lindsay, 54 years, multiparous, is undergoing a vaginal hysterectomy for a pelvic organ prolapse with an anterior wall, both of stage 2. You are about to perform the vaginal hysterectomy. Which ligament is clamped first after exposing the bladder? So here we should be very clear about the steps of vaginal hysterectomy. We all know that if we do abdominal hysterectomy, we start with fundal structures, but here we start from the bottom. So the first ligament which is clamped first is uterosacral ligament. Okay. So initial incision through full thickness anterior vaginal mucosa is given, full thickness posterior vaginal mucosa is incised, and bladder is pushed upward bluntly. Then similarly, posterior vaginal wall is pushed downward, cul-de-sac peritoneum is grasped, blade is inserted into the opened cul-de-sac. Then the left uterosacral ligament is grasped with a clamp. The uterosacral ligament is ligated and the stitch is inserted at the tip of the clamp. And then gradually we go up. The uterosacral cardinals are transfixed. Then further we go up. So here we see that the uterosacral ligaments have been grasped with a clamp and ligated first. Now let's come to EMQs. Now here EMQs are a little bit less frequently asked from core surgical skills, but yes, based on temperatures, sutures, various times they have been asked. So let's discuss. Each of the questions below discusses the temperature in relation to electrosurgery. Now, in electrosurgery, coagulation occurs at what temperature? So we should be clear about coagulation, carbonization, when all these things occur. So at around 80 degrees coagulation, that is white coagulation occurs. Cutting occurs at what temperature? So the correct answer is 100 degrees. And carbonization occurs at what temperature? So it occurs at 200 degrees. So here to answer such questions, we should be very clear about this chart. Normal body temperature is 37. Up to 40 degrees, no structural damage occurs as such. But as soon as the temperature reaches 50 degrees, cell death, all this is in centigrade, okay, or Celsius. Cell death occurs within 6 minutes. In 60 degrees Celsius, instant cell death occurs. So 50 to 60 degrees Celsius, or you can say even up to 90 degrees Celsius, instant cell death is occurring. But as it is approaching towards 80-90, desiccation and coagulation is occurring. At around between 60 to 95, coagulation, that is white coagulation, is taking place. At 100 degrees Celsius, cellular vaporization starts. Obviously, steam forms, so cellular vaporization, we can remember, and this is the temperature at which cutting occurs. At 200 degrees Celsius, black coagulation will occur, carbonization. So it is important that we have a rough idea about these temperatures and its effects. Now, this is related to adhesions related to abdominal surgery, the risk of adhesion formation. So risk for adhesions following laparoscopic surgery in a patient with no previous surgery is, if we are doing a laparoscopic surgery in a patient in whom no previous surgery has taken place. So in them, the risk of adhesions is quite low. But in patients where previous laparoscopic surgery has already been carried out, and now again we are carrying out laparoscopic surgery, so in them, the risk increases to around 1.5%. Where we are carrying out laparoscopic surgery in those patients in whom previous transverse laparotomy has taken place, then in them, the risk of adhesions will be quite high, that is 20%. Whereas in whom midline laparotomy has been carried out, there the risk will be highest, that is around 50%. So various questions, sometimes SPAs or sometimes EMQs have been asked from this concept. So you should be clear about the percentage of adhesions. Periumbilical adhesions risk, no previous surgery, it's around 0.5 to 0.7%. Previous laparoscopic surgery, 1.6% around. Previous transverse laparotomy, around 20%, and previous midline laparotomy, around 52%. So these percentages are very important and have been repeatedly asked in previous exams. So you need to take special care of them. Now here, this is based on suture material used. So suture material used for repair of anorectal mucosa is Vicryl 30. Vicryl 30 is also known as polygalactin 30. Okay. Suture material for repair of intrinsic and extrinsic anal sphincter muscle is, now, various techniques are there, overlapping end-to-end, but for repair of any intrinsic or extrinsic anal sphincter muscle, it will be either 30 PDS or 20 polygalactin. Okay, so both these can be used for repair of intrinsic and extrinsic anal sphincter muscles. What about suture material for repair of episiotomy? Episiotomy especially, we prefer to use Vicryl Rapid. So here the answer becomes D. Okay. So we should be clear about this table. Very commonly questions have been asked from this also. In anorectal mucosa, we use 30 polygalactin or 30 Vicryl. For internal and external anal sphincter muscles, 30 PDS or 20 polygalactin. Both these can be used. Various techniques you should be clear about, when to use end-to-end, when to use overlapping. So this is all. Anorectal mucosa, continuous or interrupted, 30 polygalactin. Internal anal sphincter, interrupted or mattress, end-to-end technique. External anal sphincter, full thickness tear, overlap technique or end-to-end technique. The sutures will be same for internal anal sphincter and external anal sphincter. But for anorectal mucosa, always 30 polygalactin. This is from GTG, that is OSC, obstetric anal sphincter injuries. Okay, guys, so that was all 10 SBAs and 10 EMQs of the most recent exam tested questions. So hope it is helpful for all of you. A very happy learning and all the very best for your exams. Thank you. Bye-bye.